Welcome to The Debate. Imagine if you walked into a restaurant, ordered a simple meal, and the waiter told you they wouldn't reveal the price until, I don't know, 3 weeks after you ate it.
Right. And you have absolutely no say in what they charge.
Exactly. And if you couldn't pay that surprise bill, they would bankrupt you. I mean, you would turn around and walk right out.
You'd have to be crazy to stay.
Right. Yet, that is exactly how the United States healthcare system operates every single day. Today on the show, we are dissecting the structural architecture of healthcare.
Yeah, we're looking at the skyrocketing costs and the profound inefficiencies of the U.S. model, drawing from historical, economic, and global health data.
So, the central question we have to answer today is this. Should the United States finally transition to a fully government-funded, single-payer system to, guarantee equity and rein in these runaway costs?
Or, on the flip side, does massive government involvement inherently create the very bureaucratic bloat and, severe rationing of care that we are actually trying to escape? Because if so, that would mean a deregulated, radically market-driven approach is the more efficient and humane path forward.
I will be arguing for a government-funded, single-payer system. Looking at this through a democratic socialist lens, I genuinely believe that treating healthcare as a fundamental public good, much like our fire departments or public schools, is the absolute only way to eliminate our massive administrative waste. And, guarantee universal equity for all citizens.
Well, and I will be taking the opposing position, arguing for a market-oriented approach. I contend from a libertarian perspective that heavy-handed government intervention is exactly what destroyed the pricing mechanisms in our system in the first place.
Okay, we'll see about that.
We will? But, deregulation and true market competition are required to lower costs without subjecting American patients to the dangerous systemic rationing we see in government-run monopolies overseas.
Let's ground this in the reality of the numbers, because the sheer scale of the crisis in the U.S. is fundamentally driven by this fragmented system that insists on treating human health as, a retail commodity.
Okay, but
just think about it. The United States currently spends 17.7% of its GDP on healthcare.
Right, the spending is massive.
It's over $12,000 per capita. We're spending nearly double the OECD average, yet our health outcomes are demonstrably worse across the board.
In some metrics, yes.
In major ones, we have higher infant mortality, lower life expectancy, and, worse maternal safety metrics than nearly all of our peer nations.
Sure, but...
And when you look at a country like Canada, which uses a national health insurance model, or the U.K., which relies on the beverage model, you see that centralized, single-payer government funding just drastically drops administrative costs.
Well, it drops the administrative line item, maybe.
It's night and day. In Canada, administrative costs make up about 2% of total health spending. In the U.S., it is up to 25%. A single-payer system cuts out the profit motives of private insurers, standardizes billing, and leverages national purchasing power to actually make care affordable.
The U.S. system is not a failure of the free market because we do not actually have a free market in healthcare.
We have massive private corporations making billions.
We have a failure caused by decades of heavy-handed government intervention and, frankly, poorly designed public-private path dependency. The very bureaucracy you want to eliminate was built by the federal government.
I completely disagree with that framing.
Let me finish. Furthermore, those international systems you just praised, government monopolies inevitably lead to dangerous rationing of care because they function through scarcity.
They function through budget management, not scarcity.
It's the same result for the patient. The journalist T.R. Reid documented this brilliantly in the source material when he traveled the world trying to get an ailing shoulder fixed. Under Canada's highly praised single-payer system, he faced a staggering 18-month wait just to get a routine surgery.
Which wasn't life-threatening.
But it was painful. And when he went to the UK's government-run National Health Service, the doctors told him to simply live with it. That is exactly what happens when the government dictates supply. Scaling back government mandates and allowing true market competition would drive down costs while preserving the timeliness and quality of care that Americans expect.
But that rationing you were warning about in Canada is, it's already happening right here in the U.S. We just disguise it as paperwork and bureaucracy.
How so?
Let's look at the mechanism behind that 25% administrative waste. The data tells us that the U.S. spends $925 per person on administrative costs alone. Comparable wealthy countries spend an average of $245.
Right.
That is a $680 difference per person purely spent on moving paper around. I want the listeners to picture the U.S. healthcare system as a massive toll road. But it's a toll road where the toll booths actually cost more to operate than the physical asphalt itself.
Okay, that's a clever analogy, but
We have thousands of overlapping insurance plans. Every single one has its own unique billing codes, its own narrow coverage networks, and arbitrary prior authorization requirements. A doctor's office today has to hire a small army of billing specialists just to argue with insurance companies to get paid for a service they already provided.
I don't disagree with the pain of the paperwork.
Because for-profit insurers literally make their margins by denying care and complicating the payment process. A single-payer system simply bulldozes the toll booths. You have one payer, one set of rules, and zero time wasted fighting over who pays for what.
Okay, I don't dispute the math of the $925 per person, but your toll booth analogy actually makes my point for me. Have you considered who built those toll booths?
Private insurers built them to protect their profits.
No. You're blaming the free market for a bureaucratic nightmare that was entirely engineered by federal policy.
I'm not convinced by that line of reasoning at all. Private insurance companies are the ones raking in record profits and paying their executives tens of millions of dollars. How is the government responsible for private insurance bloat?
Because we have to look at the exact mechanisms of history, specifically the path dependency created in the mid-20th century. During World War II, the federal government passed the Stabilization Act of 1942.
The wage controls.
Exactly. They imposed strict wage controls across the economy to prevent inflation. Employers were desperate to attract factory workers, but it was suddenly illegal to offer them a higher hourly wage. So what did they do? They started offering health insurance as a fringe benefit.
Right, which was a clever workaround.
It was, until 1943, when the IRS issued a ruling that cemented this forever by making employer-sponsored insurance entirely tax-exempt. That single government policy completely distorted the American market.
It locked in the employer-based model, certainly. But providing insurance through employers doesn't inherently dictate that the care has to be wildly expensive.
It absolutely does, because it created the third-party payer problem. If you are listening right now and you get your insurance through your job, you likely have no idea what a standard blood test actually costs.
Because it's a copay.
Right. You don't pay directly for the service, and you didn't even choose the insurance company. Your HR department did. Because the patient isn't shopping around, there is zero downward pressure on prices.
Well,
The hospital knows the insurance company is footing the bill, so they charge $3,000 for a $300 MRI. And then the government compounded this exact error in 1965 with the creation of Medicare and Medicaid.
wait, hold on. You're arguing that Medicare and Medicaid, programs that finally provided a baseline safety net for the elderly and the most vulnerable in our society, were structurally flawed?
I'm arguing that the legislative design of those laws entrenched a fragmented system. As the research in our material notes, Congressman Wilbur Mills intentionally designed Medicare to appease the powerful American Medical Association.
By preserving fee-for-service.
Yes, by maintaining the fee-for-service model and allowing hospitals and doctors to bill the government at what they called usual and customary rates. Do you see the mechanism there? The government essentially handed the medical industry a blank check.
Well, they had to get the doctors on board to pass the legislation.
But the result was disastrous. Every time a doctor ordered a test, they got paid more. There were no cost controls. On top of that, Medicare and Medicaid established categorical eligibility. You don't just get care. You have to fit into a neat bureaucratic box. Are you over 65? Are you below a specific poverty line?
So you want to abolish the categories?
I'm saying if you transfer this entire convoluted historic mess to a single government payer, you don't magically solve the bureaucracy. You just shift the monopoly to the federal government. If you want to bulldoze the toll booths, you remove the 1943 tax distortions, untether insurance from employment, and let consumers buy insurance directly across state lines.
forcing insurers to actually compete on price and efficiency.
I see why you think that, but let me give you a different perspective on how cost control actually functions in the real world. You say a free market and consumer shopping will drive down prices, but healthcare does not function like a normal market.
Why not?
Because when you are having a heart attack or when you find out you have aggressive lymphoma, you cannot shop around for the best price on an ambulance or an oncology ward.
Okay, but the demand is completely inelastic. You will pay absolutely anything to stay alive.
Is gouged. Let's talk about those pharmaceuticals.
Sure.
The U.S. pays roughly 2.5 times more for prescription drugs than other high-income countries. And the mechanism behind that isn't a mystery. We explicitly and legally barred Medicare from negotiating drug prices for decades.
To protect research incentives.
No, to protect profits. We left it to a fragmented web of private insurers who simply lack the market leverage to demand better rates. A single government-funded system operates as a monopsony, a single massive buyer.
Right.
130 million patients and say, we will only pay $40 for this vial of insulin. Take it or leave it, or you lose the entire United States market. That is the leverage required to stop price gouging.
I'm sorry, but I just don't buy that framing. Let me tell you why. When the government looks at a provider or pharmaceutical company and says, we will only pay this much, they aren't negotiating. They are engaging in arbitrary price fixing.
They are protecting consumers.
And basic economics dictates that when you artificially cap prices below market value, you restrict supply.
You are stopping extortion, not creating scarcity.
The empirical data says otherwise. When a government system artificially lowers costs, it doesn't miraculously make the labor of doctors or the physical materials of a hospital cheaper. It simply limits the amount of care available to the public. That is the fundamental rationing problem. We see it clearly in the source material. Why did T.R. Reid face an 18-month wait for a standard shoulder operation in Canada? Because the provincial health budget for that quarter was tapped out.
But he didn't have to pay out of pocket for it.
The price was zero for the patient, which meant demand was infinite. But the supply of operating rooms, nurses, and surgeons was strictly capped by the government's budget limit. Why did the UK's National Health Service tell him to live with a highly curable ailment? Because government bureaucrats calculated that his specific quality of life improvement wasn't worth the expenditure of public funds.
You are criticizing these international models for rationing by wait time, which, is a fair critique of resource management. But we have to be intellectually honest about our own system. The United States absolutely rations care right now, today.
How? By requiring payment?
We just ration it by wealth.
I wouldn't call the allocation of resources based on purchasing power rationing. That's simply the mechanism of how markets distribute scarce resources based on value.
But healthcare isn't a luxury watch or a sports car. It is a biological necessity. According to the data in our material, there are 28 million uninsured Americans. For them, care is severely rationed.
But no one is turned away from an emergency room.
What is the actual mechanism that happens next?
The patient often delays care.
Exactly. Up to half of uninsured patients delay basic preventative care because they simply cannot afford the out-of-pocket costs. They can't afford the $100 clinic visit, so they wait.
Right.
They wait until their unmanaged asthma or their early-stage diabetes becomes a catastrophic, life-threatening crisis, and then they collapse and get taken to the emergency room.
Which is terrible.
And the ER is the single most expensive possible setting for medical care in the entire system. They rack up a $50,000 ICU bill that they cannot pay. The hospital doesn't just eat that loss. They shift that uncompensated care cost onto the privately insured.
Yes, cost shifting is a huge issue.
They raise their rates, which raises the premiums for every listener tuning into the show right now. It is incredibly inefficient. A single-payer system guarantees that everyone can see a primary care doctor early for cheap, which prevents those catastrophic, system-draining downstream costs entirely.
Look, I completely agree that relying on the ER as a primary care clinic for the uninsured is disastrously inefficient. But you are presenting a false dichotomy here. You do not have to plunge the entire American economy into a single-payer government monopoly to achieve universal coverage or encourage preventative care. Look at the Bismarck model.
You mean the system used in countries like Germany, Japan, and Switzerland?
Yes.
The Bismarck model proves definitively that you can achieve universal, high-quality coverage without a total government takeover of the medical sector. In Germany, both the financing and the delivery of healthcare remain private.
Wait, private but highly regulated.
Yes, but private. Citizens pay premiums to private insurance companies, which they call sickness funds, through payroll deductions, and they receive care at privately owned hospitals and clinics. The system is funded jointly by employers and employees, not through a massive pool of general taxation controlled by politicians.
But let's look at the mechanisms making that system work. Those sickness funds are not operating in a free market.
The underlying architecture is private delivery. My point is, if the United States fully deregulated its hospital monopolies, which are currently protected by anti-competitive certificate of need laws, and removed the barriers preventing insurers from competing across state lines, we could achieve incredible efficiency.
I don't see how that follows.
The Bismarck model shows us that private financing and private delivery can work brilliantly if you don't bog it down with the kind of categorical eligibility and bureaucratic bloat we legislated into existence in 1965.
I am very glad you brought up the Bismarck model, because if you look closely at how it actually operates, it proves my point rather than yours.
Oh, really?
Yes, really. You are entirely correct that Germany's system relies on private entities, but you are omitting the crucial regulatory mechanism that makes it function: absolute, heavy-handed government control.
I view the private delivery and decentralized choices as the core driver of their success, not the regulations.
But the delivery mechanism only functions equitably because the German government holds it on a painfully tight leash. Those German sickness funds? By law, they must operate as nonprofits.
Sure.
They are legally forbidden from denying anyone coverage based on pre-existing conditions, and they cannot charge different premiums based on a person's health status. Furthermore, the German government imposes strict, mandatory price caps on all medical procedures and pharmaceuticals across the board.
Which again brings us back to price fixing and its long-term consequences.
Which brings us back to effective cost containment. The reason the U.S. commercial insurance market fails so spectacularly is precisely because we allow for-profit motives to operate without those strict government constraints.
But the profit motive drives efficiency.
Our system legally encourages private insurers to maximize quarterly returns for Wall Street shareholders by denying valid medical claims. It allows private equity firms to buy up rural hospitals, gut their staff, slash services, and flip the real estate. The German system works because the government explicitly removed the profit motive from basic health insurance.
Well, they restricted it.
It proves that strong central control, whether through a single-payer structure like Canada or heavy public utility regulation like Germany, is the absolute essential ingredient for keeping people alive without bankrupting them.
There is a massive structural difference between strictly regulating a market and fully nationalizing it. I can look at the German model and concede that it functions, even with its heavy price caps, because it still inherently relies on decentralized private delivery. Patients have actual choices.
They have choices within a capped system.
But providers have autonomy in how they run their clinics. The supreme danger of the single-payer models you advocate for, particularly the Beveridge model in the U.K., is that the government literally owns the hospitals and employs the doctors. It centralizes all decision-making in the hands of the state.
That isn't entirely accurate for all single-payer systems. I mean, in Canada's national health insurance model, the hospitals are private nonprofits and the doctors are private practitioners. The government is just the insurer paying the bills.
Even in that scenario, when the government is the sole purchaser of services, it functionally controls the entire market through the purse strings. And this brings up a critical mechanism we haven't touched on: innovation.
The innovation argument?
Leads the world in medical research, pharmaceutical development, and technological breakthroughs. Why? Because the possibility of substantial profit incentivizes massive private investment. Bringing a new drug to market costs an average of $2 billion and takes a decade of clinical trials.
I know the numbers.
So if you implement a single-payer system that caps prices and restricts capital returns, you will undoubtedly see a chilling effect on medical innovation. What does Pfizer do when the government dictates prices? They cancel the R&D on the next generation of Alzheimer's drugs because the profit margin just vanished.
We might artificially lower costs today, but we will sacrifice the cures of tomorrow.
That is a very common defense of the status quo, but I find it both logically flawed and honestly morally problematic. First, what good is a cutting-edge innovative cure of 28 million uninsured people and millions more who are underinsured literally can't afford to access it?
Well, they eventually get access when patents expire.
Furthermore, we know from the data that a significant portion of foundational early-stage medical research in this country is already funded by the government through the National Institutes of Health. The pharmaceutical companies take that publicly funded, taxpayer-subsidized research, patent it, and then sell it back to the public at extortionate margins.
But
The public is paying for the innovation twice.
you are severely underestimating the sheer cost of phase 2 and phase 3 clinical trials, which is almost entirely borne by the private sector's risk capital. But putting the innovation debate aside, I want to return to the concept of path dependency, because it is vital for understanding what is actually practically possible in the United States.
History dictates the board we are playing on, yes.
Exactly. When the Affordable Care Act was drafted, the architects fully knew they couldn't just scrap the existing system. The U.S. economy relies on this deeply entrenched patchwork of employer-sponsored insurance, Medicaid, Medicare, and private markets.
Which is why it's so broken.
Even if a single-payer system were theoretically superior, which I adamantly dispute, the sheer logistical reality of transitioning nearly 1/5 of the American economy to a federal monopoly would be catastrophic. You would be destroying millions of jobs in the private insurance and administrative sectors overnight.
I wouldn't call transitioning away from systemic waste a catastrophe. Yes, there would be economic shifts, but the overarching goal of a society should be the health of its citizens, not propping up an obsolete administrative industry. We transition economies all the time when better systems emerge. We didn't keep the horse and buggy industry on life support just to save jobs when the automobile was invented.
But you aren't proposing an organic, consumer-driven technological transition. You are proposing a top-down legislative mandate that seizes a massive sector of the economy by force. The ACA proved how fragile even minor government reforms are in our system.
Fragile because they were constantly attacked in court.
It relied on the individual mandate to artificially force healthy people into the risk pool to subsidize the sick. And the moment that mandate was legally challenged and zeroed out, the market destabilized again. True reform needs to align with the cultural and political realities of the United States, a nation that historically values individual choice and is deeply, rightfully skeptical of federal overreach.
And yet Medicare, a massive, purely federal health program, remains incredibly popular across the entire political spectrum. When people actually experience the security of a government-guaranteed health program that doesn't tie their survival to their employment status, that skepticism tends to fade quickly. We can see clearly through our discussion today that the current U.S. patchwork system is uniquely terrible. It is too expensive, it leaves too many behind, and it's economically unsustainable for the future.
Well, on that specific point, we have convergence. The status quo is indefensible. The disagreement is entirely about the escape route.
Right. To summarize my perspective, the root cause of our crisis is that we treat healthcare as a profit center rather than a universal public good. By transitioning to a government-funded single-payer system, we can eliminate the fragmented administrative waste that costs us hundreds of billions of dollars a year in billing armies and paperwork, which I obviously dispute. We can use the leverage of a single payer to negotiate fair prices for drugs and services. And most importantly, we can ensure that every single person has equitable access to early preventative care, stopping the catastrophic mechanism of the uninsured flooding our emergency rooms. It's an approach that values human life over market margins.
And to summarize my position, expanding government control will only guarantee that we import the massive bureaucratic inefficiencies and severe rationing seen in places like Canada and the U.K. The government created this mess starting in 1943 with wage controls, tax exemptions, and rigid categorical entitlements. The solution to a government-engineered crisis is not more government. It is a market-driven approach, removing mandates, untethering insurance from employment, and forcing providers to compete transparently on price will empower consumer choice, preserve timely access to care, and drive down costs without stifling the medical innovation the world relies on.
It is a deeply complex issue where ethical imperatives continually collide with hard economic realities. We've explored how our current model was accidentally built through WW2 tax codes, the stark trade-offs between rationing by wait times versus rationing by wealth, and the mechanisms that make international models like the UK and Germany actually function.
Absolutely. And there's undoubtedly more to explore in the source material, particularly regarding how emerging technologies like artificial intelligence in diagnostics and telemedicine might alter these economic dynamics and cost structures entirely. We encourage our listeners to weigh these trade-offs for themselves. Look at the mechanisms, consider the historical context, and decide what balance of cost, equity, and access makes the most sense.
Ultimately, we all interact with this system. The next time you open a medical bill or an explanation of benefits, look closely at the charges. Ask yourself, are you paying for the actual care that keeps you healthy? Or are you just paying for the structural design of the system itself? Thank you for joining us on The Debate.